Hello everyone, and welcome to the GAFT webinar on developing and implementing breast pain pathways. For those that don't know me, I'm Tracy Irvine. I'm a consultant oncoplastic surgeon here in the Royal Surrey in Guildford, but I am also the breast surgery clinical lead in GAFT that is hosting this webinar today. Next slide, please, Sophie. So the way we're going to run the webinar is we're just going to run through all of the speakers that are lined up on the agenda, and we're going to then have a discussion with the panel at the end. Any questions or comments that you want to post while we go through the talks, you can put into the Q&A, and if it's a specific question to a specific speaker, they may answer it as we go along. If I feel it's of value to everyone, we'll pick it up in the chat afterwards. If we don't get through all of the questions in the 1 hour that we have allocated for the webinar, we will send out an FAQ afterwards. So we will get to all your questions. This is designed, as all of the GAFT work is, to be interactive and supportive. So please use this time to get your questions answered. The webinar is being recorded, and anyone who has registered for the webinar will get sent the recording, and it will also be available on the website afterwards. Next slide, please, Sophie. So why are we here? Well, I was contacted by a number of systems asking for support with the breast pain pathways. And the breast pain pathways are particularly important because we've seen a drop-off in our faster diagnostic standard performance in breast over the last year. On the graph to the right, what you can see is the orange bar is the patients who end up with a cancer diagnosis, and these patients are the patients who are most impacted by any deterioration in performance, which really emphasizes the importance of taking patients at very low risk of having breast cancer out of our one-stop clinics so we can prioritize the one-stop service for the cancer patients. I must, however, emphasize that currently all of our breast referrals that are either urgent suspected cancer or symptomatic must still be seen within that 28-day FDS window, whether they're in a one-stop clinic or in a lower risk pathway such as breast pain. Next slide. So you should all be aware of the best practice timed pathway that we wrote some time ago with a multidisciplinary group, emphasizing the importance of focusing on the likely cancer patients in the one-stop clinic. Next slide, please. And taking these low-risk patients out. Next slide, please. But really, this is now no longer a nice to have or an optional extra. Yesterday was World Cancer Day, and NHS England released the National Cancer Plan, which includes the sentence, "We will build on these successes by rolling out breast pain and postmenopausal bleeding clinics nationally by the end of 2026. So this is not just something that a few units can set up if they feel like it. This is now government policy that we will be offering our breast pain clinics an alternative pathway. What I've done is asked some of the people involved in some of the well-established breast pain pathways to speak today, and then Jennifer Hugh is going to give an update on the ASPIRE data, and then we can have a chat afterwards. So I'm going to hand over to Claire Garnsey, who is next to speak. Thank you, Claire.
I think it's me, Tracy.
That's why I'm blonde. Mark Siebering is next to speak. Thank you, Mark, for being awake.
Thanks. Thanks, Tracy. So I'm speaking today on behalf of the East Midlands Breast Pain Pathway Implementation Team. For those who don't know me, I'm a surgeon at the Royal Derby Hospital. Next slide, please. So the problem we have is twofold. We've got a problem with our capacity in our diagnostic clinics. And in those diagnostic clinics, a significant proportion are patients with breast pain only at low risk, and that could be up to 20%. The other problem is that women with breast pain only are not getting the best care. Breast pain alone is not a symptom of cancer, but we create anxiety by throwing them into our secondary care diagnostic system. We medicalize them, we offer them imaging, biopsies, and sometimes we often may not deal with what we think might be one of the main reasons for presentation, which is a family history of breast cancer. So that's why transformation of the current pathway was urgently needed. Next slide, please. So our solution is the East Midlands breast pain pathway. It's got 4 key components. The first is that breast pain has no relationship to breast cancer, and emphasising that throughout the pathway and only seeing patients with breast pain alone. Next slide, please. The clinics are held away from a diagnostic breast service in the community, and these are the 2 sites of our initial pilot in Derbyshire, where there was a community hospital site and a GP practice. Next slide, please. It's important that these patients are seen by an experienced clinician who will be reassuring and confident and will exclude a clinical abnormality and note that there are no other symptoms apart from breast pain alone. And they will need an admin support. These are our nurse practitioners who did the first clinics in Derby. Next slide, please. And finally, as part of the assessment, we do a standardized objective risk assessment. It's not a family history clinic, it's a triage tool. We try using the NICE guidance for primary care to establish those that are at near population risk and those that are at above that risk, moderate or high, which can then be referred into family history services. Next slide, please. So this is our pathway. The initial part is in primary care, where ideally the GP would manage breast pain for 3 months according to an algorithm of treatments. We recognise in the real world that doesn't always happen, and we get the referrals inside 3 months. But when a patient is referred, we initially have a triage process to ensure that only patients with breast pain are seen and any other symptoms and signs are ruled out. We exclude those with a personal history of breast cancer because they are at automatically increased risk compared to the general population of another cancer, and those with mammary implants because they may well need imaging of implants in the clinic, and male patients. So the patients are seen in the community clinic by the clinician with the support of an admin and chaperone. They have a clinical examination assessment and they have their objective family history risk assessment. And there are 3 outcomes. So if both of those are normal, they get general advice about their breast pain management. They're given advice about being breast aware, advice about breast screening and signposted. If an abnormality is found, then they have a fast track straight into the breast cancer diagnostic clinic. So it's hitting those targets Tracy was talking about within the 28 days. If a significant family history is found, then they are referred appropriately to the local family history service. Next slide, please. So what we've tried to do, this has been a sort of 7-year project, and we've been trying to build an evidence base for this pathway that we've devised, trying to answer all of these questions. And we've done that in 4 phases. Next slide, please. The first phase was we did a small pilot at a single site in Mid-Notts, where we saw just under 200 patients, and that showed that it was feasible and that patients is acceptable to patients. Next slide, please. We then did a much larger pilot across Derbyshire at multiple sites to show that this could be scaled up and reproduced. And again, the patients gave excellent feedback. Next slide. The final phase, the third phase, was we spread it across a single cancer alliance in East Midlands, and all areas of the East Midlands Cancer Alliance introduced the pathway, and we carried out an audit of just under 2,000 patients there, and we had additional information about cost effectiveness and scalability. Next slide, please. And the data I'm just going to concentrate on today is the last phase, which is our national evaluation. So having learned from all of the pilots and the East Midlands experience, we've spread it out to 17 centres across 9 different cancer alliances in England, and the evaluation included over 7,000 patients. Next slide, please. So these are the headline data. So just about 88% of the patients were seen at the clinic and had a normal clinical assessment. So there you avoid 88% of these patients coming to a breast cancer diagnostic clinic. Only 12% needed referral into that clinic for further assessment. It's consistently picked up a level of family history patients that just over 12% were above near population risk on NICE guidance. And the patients have unanimously in all of the pilots and all of the centres found this a good experience. They found the pain advice helpful and they're reassured by it. They found the personal risk assessment helpful. And probably most importantly, 99% of them would recommend the service to family and friends. Next slide, please. This is probably best illustrated in these word clouds of the subjective comments from patients on their questionnaires, and the before and after is quite clear that they benefit from this service. Next slide, please. Just coming back to family history, I said that we pick up about 12% of patients that are above near population risk. An additional benefit of this is nearly 1 in 3 patients who attend with breast pain have a family history of breast cancer that they might be anxious about. So we're also able to reassure that 20% of patients that have got a family history of breast cancer, but actually it's not a significant family history of breast cancer, and that probably improves the reattendance rate at clinics. Next slide, please. That slide seems to have gone slightly awry. I don't know what's happened there. So basically, this is the safety data, and just under 4,000 patients had full 12-month follow-up after coming to these clinics. And if you include the eligible patients only, so 3 patients attended breast pain clinics, but they had a previous history of breast cancer and were then referred straight on to the cancer diagnostic clinic, there were 14 cancers found in this cohort, and that's an overall rate of 3.7 per thousand, well below that in the national screening programme. And if you look at those cancers, 8 of them were diagnosed through the service. They were actually referred straight on to Tywyd Great clinics and diagnosed. 3 were from directed screening from the clinics. They were diagnosed within 2 months of attending the clinic by saying they'd either not had a mammogram for some time or family history mammograms. 2 patients had a subsequent screening diagnosis where they actually, incidentally, they were 2 non-palpable cancers in the other breast to the breast pain symptoms. And there was 1 that was referred back by a GP, and that was a very difficult diagnosis that from the start point. So I think this data shows that this pathway is safe. Next slide, please. We've got cost effectiveness information. We did a full health economic evaluation, and you can see the benefit is for every £1 spent in the first year, you get £1.26 back, and by the 3rd year, £1.56 back. So again, this is, as well as being good for patients, safe, it's also cost effective. Next slide, please. So I think the answer to this question of do they work, I think we have got that evidence base. We've answered all those questions. They're feasible. You can scale them up, acceptable to patients. They seem to be safe, cost effective, reproducible. And they are sustainable. Our Derby clinic has been going for nearly 5 years. And all of this evidence is now published in peer-reviewed journals, and I put all the references in the slides for you to access if you want to. Next slide, please. So this is really all on message with the current direction of travel from all the guidance. Our pathway was recognised by NHS England and getting it right first time as a case study. Next slide, please. It's also, this is the guidance in the faster diagnosis document, and all of the comments here about trying to triage patients out, remove those at low risk, avoid unnecessary imaging, and improve care of these patients. It's all on message for this pathway for what the guidance is asking us for. Next slide, please. It's also in line with the current radiology guidelines. So the clinical radiology guidelines have been updated in the last few months, and they clearly state that breast pain alone is not an indication for imaging. They recommend that patients with breast pain only are not routinely offered imaging, but they should have rapid access, which they get through this pathway. Next slide, please. So to help those coming afterwards, we've set up a website on the East Midlands Cancer Alliance website. There are 2 parts to it. There's a patient and public area, which is open to anybody, that you can get a lot of information about breast pain and the pathway and the evidence. And then there's a second area which you need to just register to get a password as an NHS healthcare professional, and that's got a toolkit for implementing the pathway and to help anybody coming after us to trying to introduce a breast pain pathway. Next slide, please. So this is a work of a lot of different people, which I've acknowledged here on this slide. So thank you. That's all I have to say, and I will now pass on to Claire Garnsey, who's going to talk about the Manchester pathway.
Thanks so much, Mark. And good afternoon, everybody. I'm Claire Garnsey, consultant breast surgeon at Bolton, and I'm also Associate Medical Director and Clinical Lead for Breast at the Greater Manchester Cancer Alliance. Slide, please. So our Mastalgia pathway in Greater Manchester started during the COVID-19 pandemic. And we had two trusts, Manchester Foundation Trust and Bolton, who developed nurse-led telephone clinic pathways for Mastalgia patients during the pandemic, based on a publication from MFT, a prospective study that showed of nearly 11,000 women referred to breast triple assessment clinic, that of the women referred with breast pain alone, breast cancer incidence was 0.4%. So on rolling out the telephone clinic, I'm very grateful to my MFT colleagues for auditing their practice, and that has been published, showing that on running the pathway, their pickup rate was 0.6% of patients with breast pain that were diagnosed with a malignancy. And we know that because we chose initially to mammogram patients over 40 as a direct-to-test mammogram following telephone clinic. Patient survey demonstrated that 93% of patients were satisfied with the care received, and 97% said they would recommend the service to a family member. Slide, please. So as the pandemic calmed a little, we came together as a system. Have the next slide, please, Sophie. Thank you. And we held a series of workshops of senior clinicians from the whole multidisciplinary team, and we decided that we wanted to roll out the same pathway throughout the region in all 6 of our sites. We got that signed off by executive leaders of all of our providers, and the Cancer Alliance stepped in to lead the implementation of the pathway, and we were very fortunate to have a fantastic lead nurse for this pathway, Claire Robinson, who was with us for 2 days a week during the implementation, just to support trusts to on board. And I think there's huge benefits to implementing as a system. So we had the credibility that those exec leaders sign off gave us. Also, it was quite good to have a bit of peer-to-peer benchmarking, because we were all sort of making sure that we were keeping up with each other in terms of implementation. We wanted to make sure that we had equity across our patch for patients. And of course, it saves time. So the Cancer Alliance developed a lot of the resources and assets needed to implement the pathway, and it avoided duplication of effort at provider level and just allowed us to have one engagement strategy for our primary care colleagues. Slide, please. And so I would say the key priority, focus of our pathway is that referral from primary care is not required. If you just click for me, please, Sophie. And so we really focused a lot of time and energy on supporting primary care to support patients with Mastalgia with an always-on primary care education programme. Next slide, please. And so if I take you through a few of the assets, let's go from the top left and work round clockwise. So we had a number of live and recorded online webinars about breast pain aimed at primary care. We created an animation about signs and symptoms of breast disease for social media and waiting rooms. We've got leaflets for patients about how your bra should fit and managing breast pain, infographics on Gateway C, and then a management algorithm so that if GP colleagues type in Mastalgia or breast pain to their electronic system, this pops up and allows a GP to follow through management of breast pain in primary care. And we have some detail on our referral forms explaining that we don't advise referral for breast pain. And we kept in contact with primary care colleagues throughout the implementation phase through PCN bulletins to explain to them how the implementation was going. Slide, please. And the results were very positive. So you can see in the top right that from 2020, when Mestalgia as a percentage of total breast referrals was 20%, that has gradually come down to 3.8 in our best performing provider. And you can see in the top left graph, just these are where cancer is not suspected. So those referrals in that are very low risk. And you can see that our referrals per month over the whole patch have reduced from about 1,200 to about 500 per month. The bottom graph on the left shows that there isn't the same reduction in cancer suspected referrals, which is what you want. You don't want many breast pains in there to begin with. And so you wouldn't expect those to reduce. But at the same time, we're actually treating more cancers per month. So we're not getting a drop off of people with cancer. We're not missing them. Next slide, please. So we were very pleased with the impact of the primary care education programme. But of course, for those 4 or 5% of patients that cannot be managed in primary care, we wanted a really appropriate low risk pathway for our patients. And we provide that through an advanced nurse practitioner or GP with cancer role-led telephone clinic. We've not got time today to talk about the GPs with cancer roles, but it's a wonderful way of bringing primary and secondary care closer together. And we have GPCRs in all of our services, working for 1 or 2 days a week, and in all of our oncology services. Next slide, please. So this is the pathway, and you can see it's a primary care referral. You have to have triage of referrals in secondary care, and I'll come back to that in a moment. The clinics are delivered, paid for by secondary care, but often by GPs, to the patient in their home by telephone. 20-minute appointment slots. These are not easy clinics. You need people with great communication skills. And currently, patients over 40 are offered a direct-to-test mammogram. We are very keen to remove this from the pathway, but we are just awaiting those ASPIRE results just to make sure the evaluation supports that. And we spent a lot of time developing standard documentation and patient information to support our colleagues who are providing these clinics. Next slide, please. These just give you a bit of an overview of the supporting documents, which we'll be able to share with you. They're all on our website. Just to point out that we have primary care feedback letters. So this is where GPs haven't tried to manage the Mestalgia in primary care, and we send a polite but informative letter just explaining that we expect breast care to be managed in primary care, and where they can get access to the resources that can support them to do that. Next slide, please. So just to give you a bit of a view of some of the pitfalls from when we have implemented, the first thing I would say is don't underestimate the importance of secondary care triage. It's absolutely key. So we had 2 providers who initially attempted implementation without secondary care triage. So they created a separate referral option for primary care for Mestalgia, placing essentially the triage responsibility with primary. Just didn't work. So we found that primary care triage resulted in 50% of the patients going into the Mestalgia clinic having another complaint that wasn't Mestalgia, and yet 50% of true Mestalgia patients still were being referred in to triple assessment clinic. And that when we were running GP-led triage in 2 of our units, it resulted in persistently high numbers of Mestalgia referrals compared to peers, because you're just undermining that message that you don't need to refer in. If you are offering a referral pathway, pop your patient in this clinic with Mestalgia, we'll see them. That is not the narrative, the message we are giving in Manchester. The take-home message is don't overestimate the experience level required to triage. So with the support of our lead nurse, we were able to upskill Band 4 colleagues to successfully triage following a period of training and with support of a protocolized triage tool. And finally, in terms of pitfalls, I would say don't underestimate the experience level required to deliver a telephone mastalgia clinic. This is not an easy clinic for rotating resident doctors or disinterested colleagues, or colleagues lacking in strong communication skills. And we saw this early on when our rebooking rates from mastalgia telephone clinic ranged from 5 to 35%. And it was our GPs and really experienced nurses and associate specialist doctors who had the lowest rebooking rates. We advise people to aim for a rebooking rate of around 10%, but I think you have to be aware that if your primary care education program's working really well, and as your overall mastalgia referral rate reduces, the patient complexity increases, and so you might see a slight increase in that rebooking rate. Next slide, please. And so to conclude, I just wanted to talk about the key levers for successful implementation. So for us, it's all about the fact that referral from primary care should be avoided. I think this is the most effective way to support your FDS. And to do that, you have to support primary care to support the patients. Mastalgia clinic should be there, but only for those patients who can't be managed in primary care. We don't want to be offering unnecessary examination and imaging. You have to have experienced clinicians delivering your telephone clinic, and make secondary care triage absolutely key. And it's important that managers understand the value of employing Band 4 triage colleagues to do that. We are now moving that triage into a completely new phase where that triage doesn't just support mastalgia, it supports many other low-risk pathways like under 30 ultrasound clinics, low-risk gynecomastia clinics. It can triage all your aesthetic referrals. Do they have a BMI that means it fits your effective use of resources eligibility criteria? So triage is absolutely key in referral management. And to finish, I would just like to say that our view in Greater Manchester is that even if a service has triple assessment clinic, because they've got their referral rate down to 3.8, our current position is that unnecessary intimate examination of the breasts and imaging is not ethical, nor is subjecting women to the unnecessary worry of a cancer pathway or the cost of travel. So even if the referral rate goes down, we need to be providing the right pathway for mastalgia patients, which is not triple assessment clinic. Next slide, please. These are our contact details. We'll send those out with the pack. So I will hand over to Jennifer.
Thank you, Claire. I'm Jennifer Hugh. I am a oncoplastic breast surgeon at Barts in London. I am presenting this preliminary some data on behalf of the Aspire Steering and Working Group. The Aspire is badged under the ABS, and I'm one of the co-lead of the Aspire study. Next slide, please. The slide's not moving. Oh, thank you. So I think that both Mark and Claire have highlighted some of the challenges we have in our breast one-stop clinics, and it is a huge problem with breast pain. And as you can see on this slide, about most women experience, 70% of women experience breast pain over their lifetime, and a significant proportion of breast clinic one-stop referral, over 20%, relates to breast pain. Next slide, please. Again, this slide has gone a little bit haywire, but I wanted to say that on this slide to look at the what I've highlighted red on the table, in the sense that for the breast pain only patients, the risk of picking up cancer is extremely low as compared to if the patient has any other symptoms. So if the patient presents with breast pain only, the cancer pickup rate is 0.4%, whereas with any other symptoms is 5%. And then if the clinical examination is normal, then likely that can everybody hear me? Sorry.
Yes, we can.
Yeah. So, if the clinical examination was normal, it is likely that their mammogram is unremarkable with a positive predictive value of 99%. Next slide, please. So it's very expensive. I think we've highlighted in the two previous talks to come to secondary care for breast pain diagnosis. You can see that the referral cost is much higher if they were coming to a secondary care as compared to managing in the primary care. Next slide, please. So I think that we sort of highlighted in the two previous talks that why it is important to think about novel strategies to deal with the breast pain patients. And the Aspire service evaluation was set up to look at the different models that have been set up across the country. You have seen two models that were specific, but what we are doing is to look across the country what various units are doing. We obviously wanted to make sure that different strategies are all safe, hopefully, and on top of that, what may suit one region may not suit another unit, may not suit another region. So therefore, we wanted to look as an overall what's happening nationally. Next slide, please. So the primary endpoint of the Aspire service evaluation is safety, defined by the number of breast cancer diagnoses in the 12 months following completion of the assessment of the breast pathway. On top of that, we're going to look at patient satisfaction, cancer pickup rate, how quickly the assessment is completed, and whether there were any patients, again, was referred back to maybe another unit or within the same unit for reattendance. And again, we're going to also look at the cost-benefit ratio. Next slide, please. So the data for the Aspire was collected on the REDCap platform. It is a secure platform hosted by an NHS trust, and there were two phases in the collection of the data. The phase one, which is collecting patients who are attending these novel pathway clinics, and we are also collecting we are also enrolled some units who are seeing these breast pain patients embedded in the one-stop clinic. We're also collecting patient satisfaction. We can say how great these pathways are, how safe this pathway are. If we don't get buy-in from the patients and their GP, if they're not happy about the service, we are not going to win this battle as such. And then from the second phase, which is 12 months on from the initial recruitment, we're going to look at how many cancers have serviced in the next 12 months. So this is what we have collected in the REDCap platform. You can see that there are 7 columns. I think been mentioned by Claire that triage is extremely important because when the referral comes in, an experienced personnel, be it an advanced nurse practitioner, someone who's non-clinical, or whether it was a consultant to see whether these patients can go into these specific pathways, which is going to come on to later. We have pathways in the community setting and the secondary care setting, and East Midland is a very good example of how it was been successful in the community. Most of the patients that we have recruited into the study have been seen in the secondary care. We looked at how the service was delivered, whether it was a face-to-face, virtually, on telephone, or any other means like on a video. Who saw the patients? It is extremely important, as we said, that it has to be somebody experienced in dealing with breast pain, and patients handle the anxiety of the patient with breast pain. We also looked at whether there was any imaging done, whether it was routine that's written into the protocol, or whether it was based on a clinical examination and risk assessment. What resources were given to the patients and used by the team, and then what was the safety netting process if there was a patient that was found in the breast pain clinic and were found to have other red flag symptoms. Next slide, please. So just wanted to run through the timeline a little bit so that we know where we are. So we officially launched in March 2023, and last year in October, we have closed phase 1. So we are going to analyze these patients in different cohorts. We have recruited over 5,000 patients, and the PROMS is the patient satisfaction questionnaire is ranging at about 20 to 35% and is very pathway dependent, which I'm going to come on to. We have managed to get engagement with 28 units throughout England. So to break this down, and I am giving you the data that was presented at the ABS meeting last year, because that was the first cohort of patients that we have analysed. The second tranche of data will come up in the next few months. So we've found patients who have been categorised into 5 different pathways. Telephone clinic, which is remote. Patients come into face-to-face secondary care, but streamlined into breast pain clinic. Pathway that have been like the Greater Manchester, who have worked with a GP and encouraged the GP and the patient to self-manage themselves. And we also looked at imaging-only pathways, which is like the screening pathway, without seeing a surgeon, but going on to be imaged and then directed as necessary to the various clinics. We also looked at control units who are seeing patients in the traditional, bog standard one-stop clinics. Next slide, please. So when we first looked at the data last May, as of last year, as of December 2024, and which we presented again in May 2025, we had 3,800 patients, 28 recruiting units, and we had about a quarter of patients who have returned PROMs. So you can see actually from the graph or table below that most of the patients, the majority of the patients, were in the telephone breast clinic or in the dedicated breast clinic run into secondary care. In the second phase, actually, there were a lot more patients. We managed to recruit the imaging-only pathway and the self-managed pathway. So it'd be very interesting to see what the results are when we do the next tranche of analysis. Next slide, please. We looked at the cohort in terms of age distribution across the 5 different pathways, and you can see that they all overlap and is between the age of 40, just under the age of 40, 35 to about 60. So all the patients group within the different pathways are of the same distribution in age. Next slide, please. You could see that the imaging-only pathway on this slide is seen and assessed slightly later. There are some outliers in the other pathways, but most of them are seen relatively quickly in terms of between 10 and 20, well, some of them are 40 days, but 10 and 20 days. Next slide, please. So we also looked at what happened, who used imaging in this cohort of patients. 20% of patients did not have any imaging. About just under a third or over a third of the patients had imaging which were routine. So irrespective of what was found, imaging was undertaken according to their age, be it ultrasound scan, it was indicated, or mammogram, and up over 40s. 44% of these patients who had imaging were based on clinical assessment out of these 3,800 patients. And you can see actually that the number of cancers that were picked up on imaging were extremely low, 0.2% in both the routine imaging and the imaging based on clinical assessment group. Next slide, please. We picked up 7 cancers in this 3,800 patients. just want to highlight that 2 out of these 7 cancers are actually in the contralateral breast, which is completely incidental. And there were some delays in the patients with being seen quite late in the pathway in terms of 104 days and 114 days. Even then, if you look at some of the imaging that we have diagnosed as cancer, they were again indeterminate, and then the biopsy then proved that they had breast cancer. Next slide, please. So the take-home message from the patients in this cohort, or patients that we've analysed, is that the cancers are asymptomatic. The clinical examination was normal, and that the incidental pickup, or these were all incidental pickup on imaging. The only thing I guess that we may come to a little bit of anxiety is that these 7 cancers all fell outside the faster diagnostic standard. So this may be something that one has to think about when we have come up with the final data about how to set up these pathways. Next slide, please. So all the patients who were seen in the breast clinic, be it in the one-stop, be it in any of the imaging or non-imaging pathways, have been extremely happy. You could see that, not surprisingly, patients who were seen or had a telephone consultation, we had a much higher rate of returns PROMs. They were, especially when they were in the secondary setting, these PROMs were given out at the end of the clinic, so it was much easier for the patients to return these PROMs. Next slide, please. So what is happening now is that, as I said, that we are closed phase 1. We are going to complete the analysis of phase 1 patients and then go on to phase 2. And we are also going to look at various other things which are listed on the slides, and I'm aware of time. And we're also going to look at whether clinical examination and whether imaging contribute to the diagnostic of breast pain or not, which is a very important question. So next slide, please. So that's the end of my talk. And so we have a various number of people involved, and that's the end. And I'm handing back over to Tracy.
Thank you, everyone, for those presentations. I want to move very swiftly on because we've got quite a lot of questions that have appeared, and please keep posting your questions. So I'm going to group some of the questions together because they all have similar themes, and I think we need to start at the beginning. And there's quite a lot of questions. This is directed to Mark and Claire about engagement with primary care, and the comment that's been made about the resource that you're putting into the time with the patients once they come to your pathway, whether it's reasonable to expect a GP to take that on themselves and not refer given their time constraints. So I think there's 2 parts to that. What is the key to getting buy-in from primary care? And then, given that both of your pathways involve contact with the patient, is it reasonable to expect a GP to manage breast pain in 7 minutes, 10 minutes when you're dedicating longer slots to reassure these patients? Maybe just because the way my screen is, Mark, do you want to just pick that up and then we'll go to Claire?
So the first thing, it's absolutely essential at the start of setting up your pathways to engage primary care and have them involved. Not say this is secondary care telling primary care how we should do it. So in all our sites, we set up project boards which had GPs and primary care managers, as well as breast surgeons and secondary care managers all together. And that then allows you get more buy-in, and you get the GP viewpoint. You also, from our point of view, get better access to community settings because GPs will know about that. The education of GPs, it always comes better from GPs saying to GPs, this is how we should be doing it, rather than secondary care sort of preaching to GPs, you shouldn't be sending these patients in. So I'd say the key part of the first part of the question is having buy-in from the right people in primary care, to have champions in primary care that are going to, you know, drive the change for GPs. The second thing, just remind me of the second one.
It was.
Oh yeah, whether which should do it. So,
is it,
so that in our
asking the
pathway,
GP, I think.
Yeah.
Yeah.
In our pathway, we've got an algorithm of how you should manage breast pain for a GP, and we would expect them to try and do that for 3 months. But we all recognise there are some patients that are going to be more difficult. So we're expecting to be seeing here the more anxious, difficult patients that you can't expect a GP to deal with, especially if they're coming back to them multiple times. We've got data showing that patients coming to the breast pain clinics will often go 5-6 times to see their GP about breast pain. So it's a point of, you can't probably expect a GP at that point to continue to manage it.
Thank you. Claire, do you want to just add to that?
Yes, I would completely agree that you need that engagement and regular contact with primary care, and we've done that through the PCN bulletins. But you want to make things as easy as possible to allow people to adopt change. So if you have got lovely patient information leaflets that your GP can pull off the internet or have a QR code for patients, if you're providing an algorithm that they get as soon as they type in mastalgia, so that they can follow that really clearly, we found that very successful. And I think so often GP colleagues, they're very highly skilled communicators. They are brilliant at managing risk, a lot better than us, because we just turn to tests and all the investigations we've got in secondary care. But our GPs were feeling undermined, because when they did refer the patient in previously, they'd end up with a mammogram and an ultrasound and seeing a consultant and having an examination. Whereas actually, if the GP is given that education and that confidence to say, no, we're happy that you are less likely to have breast pain than someone in screening, you're just as likely to have, a cancer if you've got like elbow pain as you are if you have breast pain. And you can really strongly reassure the patient that the two are not linked and provide them with good information. The GP is very happy with that. That is a quicker consultation than it was previously when the GP didn't have clear guidance. So we haven't actually had huge issues with primary care coming on board with this at all.
Thank you. And then, as you can imagine, there's quite a number of questions about imaging. So we've got 2 different pathways, one of which has more routine imaging, one of which has imaging if clinically felt to be required. And so there's questions about, for the community clinics, do you still offer mammogram over 40? Do you offer for focal pain? Are you considering dropping the imaging? And what do you do for the under 40s? Claire, do you want to take that first, and then we'll hand over to Mark?
Yes, so we introduced this pathway back in 2020 when it wasn't in planning guidance. We didn't have the data that we have now to show how safe not doing imaging is. So we don't image anyone under 40, it's telephone clinic, and then we have a pathway, whereas if you're over 40, it's almost like doing an extra screening mammogram. You get a direct to test mammogram, you go to your nearest unit, have a mammogram, come home, and you get written to, and that's all still within the 28 days. We're not happy with that to drop mammograms, but because it's what we implemented at the start in 2020, and because we were very dedicated to submitting our data to Aspire, we have all agreed that we will wait for, as we should, to ensure it is safe, and then our intention is to hopefully drop mammograms if the data shows that.
And under 40s, Claire? Nothing
at all.
Okay. Mark, do you want to comment on imaging? I know that it's not routine. What sort of things would you refer for imaging?
There's no expectation of any imaging. So basically, the only people who get imaging are those that are directed or you're at increased risk. Therefore, we send you in for a family history screen, because they don't just then get 1 mammogram, they get 10 years of mammograms if they're at increased risk, according to NICE guidance. That's the first thing. Obviously, the patients who have got a previous history of breast cancer at increased risk, so they shouldn't be in the clinic in the first place, and they should be seen and have imaging. But we don't routinely offer any imaging apart from to those that have had a clinical finding at the clinic.
Okay.
The
And
question
there's
of
just
focal breast pain, there's no evidence that focal is any different to any other type of breast pain, and that's clearly stated as well in the radiology guidelines now.
That's great. And there is a comment about if you go down a non-imaging pathway, do we feel that that is dependent on having a normal expert clinical examination?
So we feel yes. For persistent breast pain, I say, you know, good thing if not everything shows up on imaging, but if they've got clinical, it's if you had a GP that was very confident with their clinical examination, that's fine. But if you get a lot not that confident, so we think that having a clinical examination is essential as part of the process by an experienced clinician who's not going to then flag everybody and wave everyone to a two-way clinic.
Okay, so sorry, there's so many questions coming in, which is great. There's a question about staffing, in terms of staffing the clinics. Is there consultant oversight of the clinics? And there's a question about training up non-consultants into the clinics. Mark, do you want to take that one first?
Yeah, so you shouldn't be appointing a breast pain nurse or something and send them out the community as a new appointee. You need experienced people to do this, otherwise, and I think Claire said the same with people talking to people as well. You need people who are good at talking to it and are trained to do it properly. So from the point of view of the clinician, I think it has to be somebody who's confident and able to do it. So I'll tell you how we did it in Derby. So we've got nurse practitioners in our symptomatic clinics. The consultants backfilled them in the symptomatic clinics to allow them to be the people out there in the community doing the community clinics as experienced clinicians. We've then trained up new nurse practitioners in the symptomatic clinics, not in the breast pain clinics, so they're confident clinicians at breast examination, which is a very expert skill. Over the different decades of life, it changes a lot. What is normal? Actually, it's easier to find a breast lump than it is to actually decide what is normal across the spread of all the decades. And so we've basically done it by not what you shouldn't do is train up a nurse or a body that isn't experienced and just chuck them out into a community setting with no backup. We think it's very important that you put experienced people to do this.
Claire?
Just the same, really. You can't just do this clinic without having, I would say, years of experience doing a triple assessment clinic. As I've said, this is not an easy clinic. You will have a huge upgrade to triple assessment rates if you staff this with resident doctors or people who just aren't interested. You want great communicators, particularly if you're doing a telephone clinic. So yes, all of our clinics are staffed by advanced nurse practitioners or GPs with cancer roles, and occasionally by associate specialist doctors. But yes, it's not an easy clinic.
Okay, and then just linked to that, questions come in on the sort of number of queries raised by people during the clinics. Do you are they embedded, and is it routine, or do you find that they're contacting you with questions a lot in your pathways? Both of your pathways are fairly well established. So
the clinicians asking queries from the communities, for example?
Yes, the clinic, the people in the clinic.
I think there's probably a learning curve at the start. There were probably more questions in the first few weeks and months, but now it's generally, I might get asked something about a triage thing that, can we accept this one? That's be the main thing. Very few, we've got very experienced staff doing the clinic, so there's very few questions coming through.
Claire?
Yeah, I've just put a comment on the Q&A section. I think the main queries are about triage. So triage is done by different people at different units, and that's the thing. If you are implementing as a system, there has to be some autonomy for units to make sure their staffing can staff the pathway that fits their unit. So we do have band 4 triage at some sites, and those band 4 colleagues do need some training and do need to use a protocol. We do have to have a link into a senior nurse for those band 4 staff. Obviously, as they get more experienced and they need to ask less, and lots of the patients do just follow the protocolized algorithm for triage straight into Mastalgia or straight into triple assessment. But that's been our main area that we've had to really focus training on. We've not really had questions from the advanced nurses with like 10 years of experience in triple assessment, or consultant nurses or GPCRs. They're just very, very able, and to be honest with you, do a lot better job than a lot of us consultant surgeons at having that discussion. For me, with some surgeons, breast pain is like the stuff on the side, the quick ones in triple assessment clinic, and you don't get as quality a pathway. Because if you've got 20 minutes having a conversation with a great nurse communicator, I think the outcome is often far better for the patient, and they go away a lot more satisfied and a lot less likely to come back.
Great. I'm just going to do some quick questions because we've got 5 minutes left. So, Mark, there's a question about, given that you have community clinics, are you triaging in secondary care out to the community clinics rather than have triage in the community?
Yes, we do that. Yeah, we've got a mechanism of contacting the GPs and saying, look, can we downgrade this and put it to the community clinic, please? Yes. And
another question is pregnancy, breast pain and pregnancy, an exclusion criteria for either of the pathways?
No.
Okay.
Not on our exclusion list, no.
Okay. So, Jennifer, there's a huge amount of interest in your 7 cancers. A quick question about whether any of them had previous mammogram screening in the screening program, and can you just remind people which pathways they were picked up in?
Unfortunately, I haven't got that granularity of data as such. That's something that we will be looking into. It was a very high level analysis of the first cohort. But the message I wanted to get across is that actually breast pain, not under one stop, is safe from what we can see so far.
And my recollection of your slide, Jennifer, was half of them were in a non-imaging pathway and half of them roughly were in an imaging pathway. So yeah, the pathway didn't really alter anything in terms of the low cancer detection. Completely
incidental. And I think that we are going to have a significant number of patients who have had imaging and not. So we can see, we will be able to say, I think hopefully at the end, that we have sufficient power to say whether imaging is needed or not needed, clinical examination is worthwhile or not.
Okay, and then another question for you, Jennifer. Do you have a feeling in the number of telephone clinics from the sort of spread of data in a SPA? How many telephone-only clinics do you have as a sort of percentage? You presented your range.
About a third.
About a third,
yeah.
Right.
Yeah.
That's great. I'm trying to see if I can get one more. We will get to some of these questions, I think, afterwards. How many breast pain? Here's a quick one. How many breast pain clinics do you do weekly, or how many slots do you have weekly? And if you just, I know you've got systems, but if you just talk about your own trust, Mark and Claire.
So University Hospital of Derby and Burton covers a patch of Derbyshire and a patch of Staffordshire. So in Derbyshire, we also provide the service for North Derbyshire. So we have a clinic in the centre of Derby in a community hospital and a GP practice. One is weekly, one is fortnightly. In Staffordshire, the geography is different. So we've got Burton, and then you've got Tamworth and Lichfield, which are distant to it. So we have a 4-weekly cycle, and it's alternate weeks in Burton, every 4 weeks in Tamworth, every 4 weeks in Lichfield. So people have, if they want to, local access. They can all drive the 20 miles to Burton to be seen if it's the wrong week, but they also have the option of having a local clinic.
Claire?
In our unit, we see about just over 500 cancers per year, so a medium-sized unit, and we have 1 breast clinic per week.
Thank you. Okay, I'm going to need to wrap up. I know that we didn't get to every single question, but we will answer your questions and post them out as an FAQ. Thank you all so much for engaging. A reminder, these patients do all need to have their pathways closed within FDS. Currently, that is the rule, even if there's no clinical concern. They are still FDS patients, but as you can see, you can take them safely out of the one-stop clinic. And we will get back to you. You will get a copy of the recording and we will get back to you with the FAQs. Thank you very much, everybody, for taking the time to attend. And a big thank you to all of our speakers for presenting their pathways, and to Jennifer for presenting the ASPIRE data so far. And we very much look forward to seeing the final ASPIRE data. Thank you.